The goal of this presentation is understanding how to recognise bursae, capsules and ligaments when scanning them with ultrasound. Discussing bursal anatomy in ultrasound is quite easy, as anatomical bursae cannot be seen or can only be seen as small details in an ultrasound image. In this image, we can see a transverse supraspinatus with, on top, the subacromial subdeltoid bursa, one of the bigger bursae in the human body, and the bursa that in ultrasound can be best seen in an anatomical state. The subacromial subdeltoid bursa can be seen as a thin anechoic line between two hyperechoic bursal blades. Generally, bursae are much harder to see or even invisible when in an anatomical state. This presentation is about anatomy, not pathology. I'm going to show you a few examples of a healthy bursa and a bursitis anyway. I would like to be sure that you notice that detecting a bursal problem is actually quite easy, as the bursa might not be very visible in anatomy, but in pathology it's very obvious. In the left image, you'll see a healthy subacromial subdeltoid bursa. In the right image, a bursitis can be seen. Note that the bursa is much bigger and therefore easier to see. The synovial capsule has two layers, the protecting fibrous membrane on the outside and the synovia producing synovial membrane on the inside. The capsule is reinforced with ligaments and sometimes tendons. It would be too simplistic to regard them all as separate anatomical tissues. They are, in most cases, interconnected. Just like bursae, the capsule in the anatomy is quite hard to see. If it can be seen, like on this slide with an example of the hip joint, the synovial capsule appears as a thin hyperechoic layer, hard to differentiate from the adjacent tendons and ligaments that have very similar echogenicity. The hip capsule is one of the thicker synovial capsules and therefore a good example of what a capsule would look like if you are able to visualise it with ultrasound. Just as in the bursa example, if a capsule is pathologic and contains a joint effusion, suddenly it's much easier to see the capsule. This can also be seen in the next example. This is a longitudinal extended field of the view of the anterior compartment of the knee. Please note the quadriceps tendon and the patella. A small amount of fluid in the joint and distension of the suprapatellar capsular recess can be seen due to pathology. In a healthy state, in normal anatomy, this suprapatellar recess can hardly be seen. With regard to scanning bursae and capsules, it's extremely important that the transducer pressure on the skin of the patient is minimised. Applying too much pressure with the transducer can lead to failing to visualise the fluid collection. Due to the pressure, the capsule and bursa are being squeezed and no fluid will be seen. The importance of reducing the pressure to avoid squeezing of bursae and capsules implies that muscle tension should also be avoided. The pressure of muscle contraction also leads to this squeezing of the aforementioned anatomical tissues. So make sure that your patients have a relaxed and comfortable position without activating any muscles when you're about to scan bursae and capsules. In this image, you can see an example of quite a big ligament, the coracoacromial ligament. The ligament has been scanned longitudinally and its hyperechoic fibres can be seen. The ultrasound appearance of ligaments is much alike the appearance of tendons in ultrasound. However, there are a few differences, such as ligaments are less organised. Due to this, you will see that ligaments have less echogenicity than tendons. Ligaments are, in most cases, thinner than tendons and therefore harder to scan. To optimise visualisation of as many ligament fibres as possible, it's wise to scan them longitudinal, long axis, instead of transverse.